We'll start with a case. This was a 58-year-old female, former smoker, who presented to our emergency department with chest pain. She had a CTPE, which was notable for a 11 millimeter left lower lobe nodule, which you can see here. This is negative for PE. She was referred to the nodule clinic for follow-up. So which of the following is true? Because of the pretest probability, according to the Brock model, is about 11%. A follow-up CT in 1 year is appropriate. The yield of CT-guided transthoracic needle aspiration is around 95% in this case. The yield of navigational bronchoscopy is approximately 70%. The risk of pneumothorax is higher with transthoracic needle compared to bronchoscopy, or ultra-thin bronchoscopy with radial ultrasound is significantly better than conventional bronchoscopy. So the answer here is that the risk of pneumothorax is higher with transthoracic needle aspiration than bronchoscopy. And we'll start our talk on lung nodules. So the objectives for this talk are to review the, why do we care about lung nodules? We're going to review the major changes in diagnostic modalities that have come out in the last few years, and talk about the latest as far as literature and research to help improve our sampling techniques with lung nodules. So lung nodules are very common. We find over 1.5 million in the United States each year. The vast majority of these are benign. However, they can represent the earliest clinically detectable stages of lung cancer. As you guys are well aware, the lung cancer is the most fatal cancer worldwide. The prognosis is inversely related to the stage of diagnosis. So earlier detection is significantly impactful for patients' longevity. It also impacts the cost effectiveness of their care, with stage 4 disease having the highest cost per year of care and the lowest survival. So the clinical issue at hand is, how do we differentiate benign nodules from malignant nodules without waiting too long to the point that disease progresses? And the way that we have to do that is with tissue diagnosis. So there's currently 2 modalities for minimally invasive approach with getting tissue diagnosis of lung nodules. This is transthoracic needle aspiration and the bronchoscopic approach. TTNAs are considered to be the gold standard in some centers. They have a pooled sensitivity of about 90%. However, if you look at lesions less than 1.5 centimeters, you'll see that that sensitivity drops to between 70 and 80%. The downsides of this technique is it has a relatively high complication rate, with 15% of patients experiencing a pneumothorax, 1% experiencing a clinically significant hemorrhage. That goes up to about 11% for all hemorrhages. And other downsides is staging is not possible during the same procedure. Generally, only one lesion is biopsied, although many of our patients have multiple lung nodules. And in order to best determine their next steps in management, we have to sample many of them. Bronchoscopy, conventional non-guided bronchoscopy has a fairly poor diagnostic yield. Meta-analysis from 2017 showed that for lesions less than 2 centimeters, diagnostic yield was about 34%. Fortunately, it has a very low complication rate, with about 1 to 2% of patients having a pneumothorax and less than 1% having a clinically significant bleed. Other advantages of the bronchoscopic approach is simultaneous staging and multinodal procedures are safe and possible. So patients who have concurrent lymphadenopathy or multiple nodules are generally best served with the bronchoscopic approach. But things have improved quite a bit since unguided bronchoscopy. What we're looking at here is a video of Airway Finder. This is with the navigational bronchoscopy platform, and it allows us to essentially pre-plan our approach to these nodules before the patient even enters the room using a pre-procedural CT scan. This is a virtual bronchoscopy view here, and it shows the proceduralist, essentially the approach that they'll need to go on in order to successfully target and biopsy the lesion. And this is further aided by the use of electromagnetic navigation on this platform. An electromagnetic navigational bronchoscopy essentially is GPS for your lungs. The patient, when they're brought into the procedure room, they're on a bed that has an electromagnetic field generator. There are 3 sensors on their chest, and those sensors triangulate our instruments within that field, just like your cell phone triangulates your position on Google Maps, or if you're ordering a pizza or something. It's very similar math involved. And that allows us to get very close, at least in the neighborhood of these small peripheral lung nodules. One of the downfalls of this technology is a phenomenon called CT body divergence, and that is the change in position of the lung nodule on the pre-procedural CT scan. So say a patient had a low-dose lung cancer screening CT scan with their arms at their side, or above their head, rather, and then they're spontaneously breathing at full inspiratory volume. That nodule changes dramatically in position depending on its location. When a patient is brought into the procedure suite, they're given a general anesthetic and they're placed on positive pressure ventilation, and their arms are on their side. So one of the technologies that we're using to try to mitigate or at least correct for CT body divergence is intraoperative digital tomosynthesis. Digital tomosynthesis is kind of a poor man's cone beam CT scan. We can take a 50-degree sweep with our C-arm around the patient and take standard 2-dimensional images and turn them into high-resolution coronal images and update our nodule's location. So this was studied in a paper by Matt Abudera in 2019, showing a significant improvement in the diagnostic yield of these small peripheral lung nodules. So the overall size for these nodules was about 1.5 centimeters. And you can see that the diagnostic yield went from about 55% before the introduction of digital tomosynthesis to around 80% after digital tomosynthesis was initiated there. And this is, as you can see, this is about 160 nodules. This was expanded on further with 363 consecutive nodules, looking at the 6-month diagnostic yield for this technology. And as you can see, this is a little bit of a busy slide. There's different ways that the diagnostic yield has been calculated in the literature, but using the Navigate style calculation, which is the least conservative, you can see we're about 88% diagnostic yield for lesions under 2 centimeters. So if you don't have a digital tomosynthesis, can you do any better? And you probably can. With even higher resolution intraoperative imaging. This is cone beam CT. This essentially allows you to perform a CT scan intraoperatively. There's a X-ray tube, which is underneath the patient, a flat panel detector. These are generally mounted within a procedure suite, whereas the C-arm is portable. They actually can generate less radiation and still provide you with very high quality imaging. They are more expensive, obviously, is one of their downfalls. When you are within the procedure suite, though, you can get extremely good imaging demonstrating tool and lesion, as well as utilization of augmented fluoroscopy to help ensure that you're getting accurate biopsies of the lesion of interest. In this image here on the right, these 4 planes show coronal, axial, and sagittal imaging, all showing a needle within a lesion. This was a non-small cell lung cancer. in a patient. Stage 1. Additionally, we have radial ultrasound as a adjuvant to help guide us intraoperatively. Essentially, this is a thin, flexible probe. It has a ultrasound probe at the tip of it that rotates, and it produces a radial image of the tissue that surrounds the catheter tip. So here we see 4 different panels, A, B, C, and D, demonstrating different views on our radial ultrasound. A is a concentric view. You can see the nodule very clearly, entirely around the radial probe, which is represented by this dark circle in the center. B is an eccentric view, which is the nodule just lateral to the catheter. C is called a blizzard or snowstorm, which you can see in Chicago, looking at your window most days this time of the year. But that's typical of a ground glass lesion, and D is no view. Improving views have been shown to be associated with improved diagnostic yield in many studies. But there's also the robots. It's hard to talk about guided bronchoscopy now without bringing up all the robots that are coming. Currently, there are 2 major robotic platforms. More are in development. Diagnostic yield for these technologies varies significantly in different case series, from 70 all the way up to 97%. The 2 platforms are Monarch and Ion. They're very similar, with only a few notable exceptions. Monarch utilizes electromagnetic navigation in addition to its optic guidance, whereas Ion uses a fiber optic shape sensing technology to help guide you to the nodule. This is the interface seen here for the Monarch. This is from Auris Robotic. You basically have like an Xbox style controller, and you can guide yourself out using this optical pattern recognition to help you select the correct airways, which will get you closest to the nodule. It also uses electromagnetic navigational bronchoscopy. Almost all these platforms use a pre-procedural virtual bronchoscopy and target selection interface, very similar to what I was showing you before. The Ion Robotics Suite uses, again, the shape sensing technology to ensure you're getting towards your target. It also uses a optic gating to help you with airway selection. Instead of the joystick, it has a little tracker ball here that you use to drive the bronchoscope. It's a slightly thinner camera as well. Otherwise, they're fairly similar technologies. So how do we decide what's the best choice for your patients? Transthoracic needle aspiration, as I showed, and now guided bronchoscopy have fairly similar diagnostic yields, at least based off of the published data. The problem with all this data is that it is case series. There are no high quality randomized studies looking at how patients fare when they go for transthoracic needle biopsy versus a bronchoscopic approach. So if you have a solitary pulmonary nodule, how do you best decide what to do for your patient? So that's a question we're hoping to answer with a Veritas study. Russia would be one of the centers for it. And this is a study looking at diagnostic outcomes and safety for solitary pulmonary nodules in the outer 1/3 of the chest. So if you have a patient with a solitary pulmonary nodule that you're concerned about and you'd like to get sampled, if they do not have concurrent lymphadenopathy or a contraindication to one of the procedures, please give us a call. We'd happy to get them plugged in and try to answer this extremely important clinical question. That's my email address if you guys have any questions or concerns. I might have gone a little fast. Anybody questions for me?
Jimmy, you went over some of the benefits of bronchoscopy over percutaneous biopsy. But are there lesions that you'd say are better for percutaneous biopsy? How do you decide what's best for the patient in those scenarios where you have a lesion and you'd like to get a preoperative diagnosis?
So I think it's unanswered question. If there's concurrent lymphadenopathy and the patient needs a staging EBUS, they should go for bronchoscopy because it can save them a procedure. If it's within the inner 2/3 of the chest or abuts a major airway, central lesions, I think bronchoscopic may be a better alternative. I think where the evidence is lacking is really in the outer 1/3 of the chest. What's the best modality to send them to? And that's really what this study is driving to answer. So a patient with a solitary pulmonary nodule without lymphadenopathy, no pleural effusion or anything else, it would be easier to sample to determine, a diagnosis. That's where we don't know the best way to manage and refer these patients. It's generally guided by this clinical expertise and referral patterns and not by any high-grade evidence. So that's one of the reasons why this study is so important, is because that's a extremely common clinical problem, given the frequency of which we find lung nodules in the United States, and we don't have clear guidance on how to refer these patients. The study is a non-inferiority study, and I think if we find that bronchoscopic biopsies and transthoracic needle biopsies are similar in diagnostic yield, the safety profile of bronchoscopy would lead me to want to refer my patients to that, as what I want a family member. So complications are significant and costly, and if we can avoid them and achieve similar or non-inferior outcomes, I think that's very valuable for the patient.
Jimmy, I have one other question to let you go. How close are we to answering the question about diagnosing and potentially treating these small tumors bronchoscopically? Because that's a holy grail, right?
Yeah.
Finding a cancer and then treating it.
I think, yeah. So there's a couple different modalities of ablation, new wave radiofrequency ablation, things like this that have been tried at a couple centers throughout the country. Just small single center feasibility studies. We are hoping to participate in them when they become larger multi-center studies. Of course, it's a tough thing to do because you really need to pick a really specific type of patient. The outcomes for T1 N0, surgically resected non-small cells are excellent. So sending a good operative candidate for radiofrequency ablation is kind of tough, especially given the lack of evidence of it being even equivalent. So I think we're going to need to find a patient population of non-operative candidates, compare them to, external beam radiation, SBRT, and see how they fare against that group. And then if it is really excellent outcomes, and we can kind of push the envelope as far as who we're willing to treat with a non-surgical approach. It is the holy grail, diagnose and treat in one procedure, but I think we're quite a ways before having that be reality.
We've got a couple of questions from the audience here. So is there a maximum number of nodules that you can biopsy either transthoracically or transbronchially?
So transbronchially, we do, 2, 3, generally without thinking much about it. We'll do bilateral lungs, multiple lobes. It's the complication rate is so low that it doesn't really matter. Transthoracic, when you're talking about a complication rate of pneumothorax around 15%, I think going at multiple targets on the same laterality is possible. Doing bilateral with the risk of having bilateral pneumothorax is quite a bit more concerning. I don't know that a lot of interventional radiologists are willing to do that, but again, that's not something I do regularly, so I would have to defer to them.
And Dr. Katzis, do you recommend getting a PET scan before biopsy, or do you think that these patients is that helpful?
PET scans are generally helpful in the workup of thoracic malignancies. They're not a bad thing to get. The question is how much will it change your management, and that varies significantly based off of the patient. So in the Midwest, there's a tremendous amount of histoplasmosis. We have a lower sensitivity and specificity for finding malignancies using PET scans as your major diagnostic modality because of all the fungal infections we have. It may provide you with a site of metastasis that is easier and less invasive to biopsy. So there's value in that, and it may help you exclude extrathoracic metastases. So there's always value to the PET scan, but you need to interpret it in the right clinical context for it to be most beneficial to the patient.
We'd like to introduce Dr. Mihir Bayani, who's one of our ear, nose, and throat specialists. Go ahead, Mihir, and take it away.
Can you hear me now?
Yes.
All right. Perfect. All right. Thank you. Again, I'm it'll be great following that amazing presentation. Jimmy, that's some great stuff that you're doing. So I'm going to kind of simplify it then, and kind of talking about thyroid nodules, not as exciting as navigational bronchoscopy, a lot of two-dimensional work, but something that I discovered in my own practice really is a patient service driven tool to have in your armamentarium, and sort of the modern head and neck surgical world as well as the endocrine surgical world. It's really a critical skill set to have. And so I'm going to kind of talk about just sort of the diagnostic approaches to the thyroid and how in-office ultrasound can benefit us. Again, nothing to disclose about thyroid ultrasound that's relevant here. Unlike lung nodules, where and I may be speaking out of turn here, but most lung nodules, that are larger, are malignant, and it's rare to see lung nodules that are not malignant that are greater than 2-3 centimeters, and so you're always having to intervene there in the pulmonary world. Thyroid nodules are very common, and as we age, we tend to see significantly more thyroid nodules. And the way I quote it to my patients is about, if I went into a room of 100 people, 35 to 40 of them would have a thyroid nodule. And if it was a room of 100 women, it would closer to be 50 to 55%. So, so it's very common. And the prevalence increases with age. Well, so if it's so common, why do we care about it? Well, about 10% actually harbor malignancy, and there is a high-risk population that's associated with that. Children under the age of 18, men, adults that are under the age of 30 and over the age of 60. And those who've had radiation exposures, it's actually something really important if you're in the Chicagoland, because there's a heavy Eastern European population that lives here, and they have all so it's important to sort of understand what their immigration history may have been if they were not from Chicago originally, and could they have been exposed to Chernobyl? And then in not too long ago, about 15 years ago, there was the Fukushima disaster. So the individuals who have emigrated from Japan, they were exposed to radiation as well, low levels radiation, and so it's important to sort of understand what that exposure history was, and then obviously family history. If you have a family history of thyroid cancer, it opens the door to want to be a little bit more aggressive in how you intervene with these patients. So if we're detecting all these thyroid cancers, are they important? So, this is data from Laura Davies. She looked at a SEER data set, and this was about 15 years ago. And she noted that, papillary thyroid cancers are growing in incidence over the last 2 decades. And what's important is that understanding that the number of nodules that are seen that are smaller are higher. And it's sort of a sign of, we're actually just catching these thyroid nodules and these small thyroid cancers much earlier. And it's related to, the imaging that we do. We get, if we're short of breath, we go to an emergency room and get a CTPE. If you are getting your carotid ultrasound, you see a thyroid nodule. So the workup begins from there. And so I think that's why we see it. Now, is it bad? Well, if as the incidence goes up, the mortality was going flat or remain flat. And so are we doing too much for these patients? Well, that's sort of changed. Julie Sosa's group, she's an endocrine surgeon. She was, I think she's now in San Francisco, or still in Duke. But she did some work again with SEER that's more modern and found that actually, although the mortality is flat, what we're seeing is that we're seeing a significant increase in the number of patients who have regional disease. And so it's important to sort of understand that, we still need to treat these cancers like they're cancers and not ignore them, because as we see more regional disease, we're potentially putting patients at risk for, local regional recurrence and even distant recurrence, where then it becomes an issue regarding survival. And so this sort of describes sort of the mortality of these patients, and you see that the mortality continues to rise in these papillary carcinomas. And again, they all had some degree of regional and distant disease at the time. So again, really important to sort of understand that as these patients are diagnosed with thyroid cancers, we don't treat them as benign disease. So when we evaluate the thyroid nodule, ultrasonography is the gold standard. Our portable devices allow for sort of improved in-office access for patients, and in same day fine needle aspirates can be done, and actually we can also do molecular testing at the same time. This is our portable ultrasound in our office. Standard Sonosite Fujifilm. You can move it around from room to room, so you don't have to necessarily have it stationed in one area. And they take 4 to 5 second cineclips, so that if you need to sort of push the video forward or backwards in order for diagnostic measurements, you can as well. This is sort of a nice diagram of what we consider a normal thyroid ultrasound. Obviously our thyroid gland is well positioned here. Interestingly, this patient actually her esophagus is on the right side, which is a little unusual. Usually you see them left-sided, but and then you see the trachea, and then the carotid and jugular vein. You can always distinguish the jugular vein from the carotid because of its compressibility. So how do we approach these patients? We use the ATA in terms of the 2015 guidelines. There should be a new set of guidelines coming out in the next year or two. I know that there's the higher risk cancers are starting to come out with their guidelines slowly. And so we want to minimize harm, reduce over testing and treatment in this low risk disease process. But again, treat those patients that have high risk disease. So when we look at a thyroid nodule, we look at specific characteristics that sort of classify them as more likely to be benign versus malignant. We look at their echogenicity. We look for calcifications within them. We look for a halo sign, and I'll kind of show you those shortly. And then margin as well as vascularity. I'm not a big fan of using the vascularity as a driver for malignancy because it's just, the thyroid gland is such a vascular organ that it's hard to distinguish, what's truly hypovascular versus hypervascular. So, this is a thyroid nodule where you look at, where it's taller than wide. And again, it has to do with the horizontal diameter versus the AP diameter. And if that ratio is greater than 1, then, it's considered taller than wide. This is another thyroid nodule. A patient of mine came in and incidentally was found this, and it's a hypoechoic nodule. It's got some microcalcifications, and it's got a thin halo around it. So how do we classify the nodules? So, the American College of Radiologists has a TIRADS scoring system. It's thyroid imaging and radiology and diagnostic scoring system. And they go from 1 to 5. And they assign these points for these individual nodules. And when you look at the nodules and their scoring, it gives you a probability for potentially it being malignant. So it gives you some onus to want to pursue biopsy in these patients. So, there was an evaluation from Britain that looked at over 1,000 nodules and applied this TIRAD scoring system. And this was sort of the predictability for malignancy. So again, anywhere from 0 to 3% for the 1, 2, and 3s, and then TIRADS 5 up to 85%. Some smaller studies actually will look at the 5 closer to 100% predictability. So the ATA sort of used that as a guidance for us to look at who gets a biopsy. And so they went from completely benign, which is a pure cystic nodule, to these higher suspicious nodules, which have a greater probability of being malignant. And then from that, you kind of look at, if you're a very low probability nodule in terms of its TIRAD score, you don't really want to biopsy a nodule unless it's greater than 2 centimeters. The lower suspicion to intermediate suspicion, about 1 to 1.5. And then the high suspicion ones, you want to go over 1 centimeter. And the reason you only want to biopsy thyroid nodules greater than 1 centimeter is that, out of Japan, they have 10-year data that shows nodules less than 1 centimeter. These what we call papillary microcarcinomas, the risk of progression in those is so low that, you actually just observe them. So, and that's actually in the guidelines in Japan and the United States. The guidelines don't dictate that because, our marketplace wouldn't allow for suspicious nodules to go undiagnosed. And so we end up having these patients diagnosed and, many of them go on to have surgery, but a more limited surgery at that. There's a great study out of Memorial Sloan Kettering that looked at observation in these microcarcinomas. However, I don't know if that's ready for prime time in our marketplace. Just as a general rule, it's very hard to sort of remember a lot of these things, these details. And so I tend to tell my patients, if it's greater than 1.5 centimeters, and they're willing, I'll do a biopsy. And so again, it's really difficult to sort of follow this algorithm, but really, we try to make sure that, patients who have low suspicion pattern nodules, we try to reassure the patients in saying that, a needle biopsy is not required, but, in reality, a needle biopsy is not that difficult. And so if the patient's really concerned and it would give them some peace of mind, I tend to offer it. So this is my typical setup. 3 passes. I have Cytolite for creation of cell block, the fixative for the slides, and then 1 empty specimen container for air dried slides. This is just the setup for how we approach our patients in our procedure room, and one of the cool things that that we have at Rush is that for those of us who run sort of relatively busy clinics, this is our physician assistant Ashley. She's been trained to do these biopsies, and so as patients kind of are able to come through, she runs a parallel clinic to us, and we can say, hey, there's a thyroid nodule that has come in. Let's put them onto your schedule so you can do a biopsy. So now we've done the biopsy. Well, what now? We get results, and it's not as straightforward as benign and malignant, because a large percentage of these patients come back with these indeterminate results, and in the Bethesda classification, which is how we look at nodules, anywhere from 3 to 5 is considered indeterminate, and each has an increasing probability of malignancy. The problem is that it's not enough to sort of justify a patient going towards surgery. So if you have a patient that has a 20% chance of malignancy, are you going to put him through a thyroid surgery? No matter how experienced you are, no matter how low your complication risk rate is, greater than 0 is still a higher risk. So worth considering. And I will say, I was an expert witness in a case where a patient did bring up a lawsuit against his surgeon, who the patient had an indeterminate thyroid nodule that turned out to be benign after all, and patient basis for his lawsuit was that he was put on Synthroid the rest of his life, which has significantly altered his quality of life, and unfortunately that lawsuit ended up being settled in favor of the plaintiff. And so it is important that we understand that, these indeterminate thyroid nodules, we need to make sure that we have a good justification to pursue surgery. So I showed you a nodule earlier, a patient with a 1.5 centimeter hypoechoic microcalcified nodule. The result of that was atypia of undetermined significance. So Bethesda class 3. And how we're able to tell that is that you see some nuclear grooving, and you see some nuclear clearing. And so in those patients, we're not 100% sure if that is truly carcinoma. So what do we do now? We repeat the biopsy. What if it's still AUS? Surgery is an option as well. But again, I brought up the litigation situation as well, and the risk, obviously. And so genomic classification is now sort of the gold standard in indeterminate thyroid nodules. So there's 4 commercially available molecular tests available for these patients. They're from Afirma, Thyroseq, Thygenex, and Rosetta GX. At Rush, we use Thyroseq. It's on its third version, and each has its own particular advantages. ThyGenX and Rosetta GX are microRNA-based studies. The ThyGenX one is that they have an 8-gene panel where if you test positive on that 8-gene panel, you don't move forward to the microRNA classifier. But if you are negative on the ThyGenX, you will move towards the microRNA classifier. It's a little easier to do the Thyroseq and ThyGenX because you can actually take tissue off the slide. The Rosetta GX, you can also take tissue off the slide, but the classifier system isn't well proven. So. But, just for understanding of what the performance of the GEC, the Afirma, the reason a lot of patients use that, a lot of providers use that is because it was sort of the first to market. And so people are used to its handling. And they provide the box and the kit, and you just send it right back to them. But my concern with the Afirma panel is that positive predictive value is about 47%, and the cost, it's about $6,400 for the patient. And so it's something to consider there. Again, the Thyroseq version 3, it's something that I use a lot. And, again, it's about $3,200 per nodule. But again, the positive predictive value is a little bit higher. And the ThyGenX, a little cheaper. Now, with the ThyGenX, if you're positive on the 8-gene panel, which is about $1,700, you don't have to pursue the thyromere component. And so something to think about with that utility. But the positive predictive value is about 75%, which is pretty good. And then the Rosetta GX. Now, something to keep in mind, though, is that you see that each negative predictive value is above 90 to 95%. So, the way I counsel my patients is that if you get a negative test, I treat it as a benign nodule, so you don't have to pursue any additional treatment after that. So, in summary, thyroid nodules are quite common. In-office ultrasound provides a safe, quick tool in evaluating thyroid nodules and allows for immediate biopsy. Again, it's a really important component of my practice, and even just doing lateral neck ultrasounds, it provides staging for lymph nodes as well. And then advancements in our molecular testing allow for sort of more personalized treatment in these indeterminate thyroid nodules, and again, the negative results really truly allow for a safe observation. So our future, we need to work towards innovations in our molecular signatures to better define the histologies, because there's some more unpublished data coming out, but they're looking at the positive molecular tests. Those patients actually have what are called NIFT-Ps, which are these they're called non-invasive follicular thyroid neoplasms with papillary features, and they're these very low-risk thyroid cancers that essentially are benign in behavior. And so, are the molecular signatures able to truly define the different histologies? And then the future really is therapeutic interventions. It was brought up again with the lung nodules, with the navigational bronchoscopy, but Rush has initiated a radiofrequency ablation program. Dr. Sean Wren and I are doing that. And then interventional radiology is able to do ethanol ablation, and then thermal ablation is being done in Europe, but it just allows us to, provide a non-surgical approach to these thyroid nodules so that patients are taken care of. So thanks, and I'll take questions.
Dr. Bariani, that was a fantastic talk about thyroid nodules and the way to work them up. Just wanted to get your thoughts. I know you mentioned it here at the end, but what do you think are some of the benefits of RFA and some of these other technologies that are coming out here? And can you just talk a little bit about what it's required before you would undertake a procedure on a nodule like that? for a patient?
So, again, it's a very new procedure, probably about, it's only been FDA approved for about 2 years. What it provides is the ability to, treat thyroid nodules that are compressive, and also some of these indeterminate thyroid nodules, to ablate them and, reduce some of the compressive symptoms and also eliminate the thyroid nodule, if it's an indeterminate, and even in the, non-operative candidate, to treat the cancer as well. Who do we work up right now is, we're starting a little slow with our program in terms of, we're looking at patients who've had only benign histology. As we sort of expand our portfolio with these cases, we will move into the indeterminates, hopefully soon. But really, right now we're working on with the benign cases. And, in nodules less than about 4 centimeters, you only need about 1 treatment, and you tend to see about a 90% reduction in the size of the nodule over a 2-year span. It's about 70% reduction in about 1 year.